We are live.
Good morning, everyone. I'm Dr. Meenal, Medical Manager for Sanofi India. Extend a warm welcome to one and all who has joined. First of all, thanks for choosing this webinar to attend on this beautiful Sunday morning. If you have any questions, as always, put them in the Q&A box below and we shall take them up as the time permits. So today, we are gathered virtually for first United Disease Conclave with the Association of Physicians of India. This is going to be a wonderful session of 2.5 hours with 3 Indian experts from various geographies and various specialities. Also, this is a CME accredited session, about which I'm sure you are already aware, but just wanted to emphasize the same. We have Dr. Rajadhar, who is an eminent chest physician. We have Dr. Soumya, who is a famous ENT surgeon, and Dr. Soni, who is a very well-known consultant physician. So without any further delay, I will start with the introduction of our first speaker, that is Dr. Soumya, who will be discussing about implications of COVID-19 on AR management and the importance of drug repurposing. So just allow me to share her introduction with all of you. So Dr. Soumya is an associate professor at St. John's Medical College. She is the secretary of Indian Academy of Allergy. She is also a member of various other associations. She had been a principal investigator of 3 ICMR and 1 DST research projects. Also, she is having multiple international publications and lectured at international allergy conferences. Her areas of interest are allergy and rhinosinusitis, as you can see, and many more. So with this, I would like to hand over the session to Dr. Soumya for your talk, ma'am. Over to you, ma'am.
Thank you. Thank you, Dr. Meenal, for your kind introduction. And good morning to everyone who has joined on a Sunday. This topic today is very interesting. Let me share my screen. Let me start with that. Is it audible? Is my screen seen?
Yes,
Yes.
Okay, thank you. So today's topic is drug repurposing. Now, this is a very interesting topic and something new for me also. So I had to read several publications and understand a lot of things. This is now the need of the hour because we have been ravaged by COVID-19 last year and even this year, and we really don't know what the future holds. So when we were off guard after we came out of the first wave, and then we thought that, okay, Indians had better immunity. We are not going to have so much of a harsh wave like the US or Europe suffered. But we were taken in for a surprise, and the second wave was very severe. And the after effects of the second wave are still to be, palpated in the hospitals. Mine is a tertiary care hospital in Bangalore. I'm associate professor in St. John's Medical College. In the month of between May and June, all the hospital beds, around 1,500 of them, were filled with COVID patients. So we had a huge COVID load, and we had to unfortunately turn away so many patients who came. And COVID took precedence. Treatment of COVID took precedence over every other disease that was there. So we postponed all our surgeries, we postponed anything and everything. We seemed a little inconsequential considering COVID. So allergic rhinitis and asthma were two things which were given stepmotherly treatment. We did not bother much about allergic rhinitis because of our COVID burden. We almost said that, okay, this is not so important that we have to look into it. And we saw that patients with allergic rhinitis worsened. Okay, they had worsened symptoms, and even asthma exacerbations were seen. So I will be talking about, in my first half, how we try to manage patients with allergic rhinitis and how our understanding of COVID-19 has changed. The second part of my talk would be about drug repurposing. Now, this is very fascinating, and it's a total fertile field for ideas and research, and for us to change and tackle COVID-19 and also other viruses. Okay. So the risk of COVID-19 in pandemic and allergic diseases, we saw that there was prevalence of allergic diseases, including asthma and allergic rhinitis in Asian countries, in which viral infections are major triggers. So there was always a probability that aggravation of asthma and other allergies, could be there with COVID-19, and this has to be considered despite inadequate evidence. Now, why I would say inadequate evidence is there is a lot of contrasting publications and the data which has been thrown. If you can observe, this is in September 2020. So here they've said that we should consider the possibility of bidirectional influence of COVID-19 and asthma and allergic diseases. So, it might be that COVID is exacerbating allergy or allergy is exacerbating COVID-19. So it could be vice versa. There was another article which you can see in JASI 2020, which talked about the possible pathophysiological mechanisms in underlying allergy. So they said that allergies had impaired secretion of innate interferons. Because of this impaired secretion, the body was very susceptible to any sort of a respiratory viral infection. So the analogy was that these people are more prone to COVID-19. Also, COVID itself could potentially exacerbate allergy. Okay, so this was a study which was published by JASI in 2020. And they also noted that atopic dermatitis did not show any potential association. Means only those with allergic rhinitis and asthma in the past had more severe COVID-19, but those with atopic dermatitis was not affected so much. So they felt that there was a local immunological environment in the respiratory system which had to be altered for this virus to affect the body. But look at how things change. This paper now, and then, then also they said that can asthma be a risk factor for severe COVID-19 infection? So they said that expression of airway levels of ACE2 inhibitor is lower in atopic subjects compared to non-atopic subjects. So type Th2 high endotype of asthma may be at a lower risk for severe COVID-19. So the first paper which came out said that patients with allergic rhinitis and asthma had more risk for COVID virus. Then there was one more which said that since the ACE2 receptors to which the COVID-19 binds in asthmatic patients is lower in atopic patients, COVID-19 binds to the ACE2 receptor in the airway. And it is noted that this is lower in all atopic subjects. So people with asthma are comparatively safe. Okay. Then there was one more study. Now, this is the latest in 2021. Okay. A review of current evidence, which says that there is no evidence thus far that allergic rhinitis modifies susceptibility to SARS-CoV-2 infection or severity of COVID-19. So they refuted what was the study found in 2020. And then they said 2020 said that allergic rhinitis and asthma were very prone. Patients with this were very prone for COVID-19 disease and they suffered more morbidity. But in 2021, it has completely taken a U-turn. They say that it is not so. They are not more prone or more at risk. Also, they recommended that we should use antihistamines and intranasal steroids. Now, this is one important dilemma that all physicians had, whether we should give steroids. We know that steroids will dampen the immune system. So giving intranasal steroids into the nose, especially where this coronavirus will colonize, will it aggravate? Okay, so after 1 year of study, they came to the conclusion that yes, we can give intranasal steroids. And they also said that nasal conditions such as allergic rhinitis and chronic rhinosinusitis do not appear to be high risk for COVID. But I would like to caution here that the sun has not yet set on coronavirus, COVID-19. We don't really know what it is. We are still floundering. Scientists are not really sure what exactly is the mechanism the virus works on because it is mutating so fast. There are so many variants already, alpha, beta, kappa, lambda. And so there's a joke that, all the Greek alphabets will be filled by this mutant coronavirus. So we need to have more studies to really know if allergic rhinitis, chronic rhinosinusitis, and asthma do influence COVID-19, or COVID-19 influences these conditions. Okay, so more studies, more data is required from each and every country. So the challenges that we faced when we were treating patients in our tertiary care hospital, one of the biggest challenges was to differentiate between allergic rhinitis and COVID symptoms. They were almost very simple. Okay, so patient had red, watery, itchy eyes because of allergic rhinitis. And we also saw that conjunctivitis is one of the features of COVID-19. Patients also complained of itching in the ear or dizziness, but we saw that vertigo was also seen with COVID-19. And there was stuffy nose and sneezing. So this was one diagnostic challenge, and it was difficult because the patients also were scared to come to the hospital. They also felt reassured, okay, it might not be allergy or anything. I mean, it might not be COVID, just an allergy. And they used to pop their usual Montelukast, fexofenadine, levocetirizine, these tablets, until it worsened, and then it became COVID. There were others who came to the hospital thinking it is COVID, but then we had to dismiss them off saying it is only allergic rhinitis. So you can see that there is an overlap here between COVID-19 and allergic rhinitis. Both of them can have cough, there can be headache, fatigue, sore throat can be there, nasal obstruction, rhinorrhea. Okay, so all this was there. But allergic rhinitis will have more of sneezing and that itchiness, which is not there in COVID-19. And so, like I told you, because of this mutation, there has been a lot of difference between the waves. The second wave has been very different from the first wave, and we really don't know what the third wave is going to be. Okay, so we have to be armed in all ways. We have to think in all ways. Now, what was glaring the difference between the first wave and the second wave was, in the first wave, we saw there was more related to respiratory system. So patients developed pneumonia and they were admitted for that, or they had cough. Okay, but there were less cases with, and it was more severe respiratory system was attacked, less cases with breathlessness. But in the second wave, we saw diarrhea. Very commonly, we saw gastrointestinal symptoms. Dry diarrhea was there, more cases with breathlessness were there, and patients deteriorated quite fast also. So even we had to adapt ourselves for the management in the hospital for the allergology practice. We almost stopped doing our skin prick testing in the allergy clinic because we found that the proximity was too close. And for 45 minutes, we are trying to do the skin prick testing, the nasal endoscopy, and all that is a very high risk situation. So see how the difference is. In the diabetic care facility, the patients are separated by 2 meters, but now the doctor and patient themselves are separated by the distance. Also, we didn't have a mask or anything. Now we are covered completely with PPE. And also there is a barrier between the doctor and the patient. So tests like spirometry, oscillometry, the bronchial challenge test, all this we had to stop. The nasal nitric oxide, so many things we could not rely on. So it was basically a history, and more importantly, and the history which superseded or overtook clinical examination in the COVID pandemic era. So how did we manage allergies, and what are the recommendations to manage the allergies during the pandemic? So the respiratory symptoms can cause difficulties in the physician's management. It can be very confusing for the patients also. So it is important that we have a triage. We prioritize patients who are very sick versus those who can be managed. Okay, a face-to-face visit is very difficult for allergic rhinitis patients and asthma. So we did not encourage that unless, of course, they had a severe exacerbation, because we did not, we had to first differentiate whether it was COVID or asthma. And also they're more at risk for developing complications of COVID. So we did a triage and we had to admit only those who showed severe symptoms. Telehealth, telemedicine, this was used very much. Okay, so a majority of my patients contacted me through telemedicine. So we saw that we gave them the medications for their asthma and allergic rhinitis. And we did a follow-up on them after 2 to 3 days, depending on their severity. So telemedicine played a major role. There was also prevention measures from the healthcare workers, because we do not want people sneezing and having an aerosol dispersal. So the way forward was telehealth management. Probably this is going to be the scenario for the next 2 to 3 years. A telehealth triage and a telehealth prescription. So based on the triage, we decide whether we have to have a face-to-face evaluation, again with the PPE. So what about the current knowledge about COVID-19 and through various studies from various countries? The recommendations are that intranasal steroids can be continued in allergic rhinitis at the recommended dose. It has been shown that intranasal steroids have not worsened or have not depreciated the immune response. Okay, so they have no bearing on the immune response. So it does not allow extra increase. So please continue to use the intranasal steroids for your patients. Stopping the local intranasal corticosteroid is not advised. Suppression of the immune system has not been proven, and more sneezing after stopping means more spreading of coronavirus. So we should also be aware of that. There can be patients who have just both allergic rhinitis and coronavirus. It is possible. We have seen such patients. But it is better that we control the allergic rhinitis so that they do not become big aerosol spreaders. Avoidance measures are first line of management still in allergic rhinitis. Pharmacotherapy for mild intermittent allergic rhinitis with second generation non-steroidal oral antihistaminics can be given. An added benefit is to reduce the aerosol transmission, and intranasal corticosteroids are recommended. Okay. An important thing that you would like to add up during this pandemic would be the intranasal saline douching. We have seen that when the patient does a lot of saline nasal douching, the viruses, the biofilm, all that, it can be removed, it can be decreased, as a result of which it might have a beneficial effect. We are not very sure with COVID-19 virus, but we have seen from earlier literature that intranasal saline douching can decrease the viral load, and practicing of social distancing and isolation remains the same. Fluticasone furoate has got very good receptor affinity with minimum systemic bioavailability, so this can be used. And along with that, we can also use montelukast and levocetirizine, or montelukast and fexofenadine. So that is how we manage the allergies. Now coming to the second half of my talk, which is very interesting. This is about drug repurposing. Now, what's drug repurposing? The rapid spread of COVID-19 has focused the efforts of scientists on repurposing existing drugs. So there are drugs which inhibit the viral entry, endocytosis, genome association, translation, and replication. So in simple words, drug repurposing means a drug which is already present in the market and used for something else. That can we try to see if that can be used for COVID-19. Now, why should we do this drug repurposing? So it is important for us to do drug repurposing because COVID-19 has not given us time to breathe. It is spreading so fast. It is causing so much of havoc, so much of mortality and morbidity, that we have very little time to sit and do elaborate research and devise new drugs and have clinical trials, do animal models, experimental models, and we cannot observe a drug and its effects over 10 years to see if it is safe to be used in humans. So drug repurposing is using basically drugs which we are already very familiar with. Important examples of this are, like for example, thalidomide first was used for vomiting in pregnancy. Later they found that thalidomide can be used for multiple myeloma. Okay, so they stopped using it in pregnancy because it has got congenital deformities it can cause. But it was seen that it does magic in multiple myeloma. Similarly, sildenafil. Okay, all of us are very familiar with sildenafil. It was initially used for hypertension and atherosclerosis, but later they realized that it has excellent results for erectile dysfunction. So drug repurposing is by serendipity. Serendipity means we are trying to treat something else, but the benefit has been felt somewhere else. Okay, serendipity, by chance. By chance, we stumble upon a drug which is going to change the game. So this involves the investigation of existing drugs. It saves cost and resources because this drug we already know, it has been used for so many years. We know its safety profile, we know its side effects, we know what is the dosing. So we really don't need to worry too much about it. We need to see if it will help in the new disease. And there is also an established safety and the new mechanism of action for a particular virus. Now, for example, COVID-19 virus. For example, I want to use Montelukast. So I know Montelukast is safe. I know that Montelukast can be given in a certain dosage and over so many days and nothing happens. So, okay, I know all the safety profile and it is a nice, safe drug. So let me see if it will work on COVID-19, okay? And we also have an established supply chain so that we can get access to the drug. We are not like struggling with like amphotericin. We struggled so much to get amphotericin during mucormycosis because amphotericin is not used so commonly. So people had the drug makers had to manufacture it at astounding levels, and still we were in shortage of it. Now look at this interesting slide, how Montelukast is effective in mitigating the cytokine storm. This is the COVID virus. Okay, this is the phospholipase A2. It's acting on arachidonic acid and leukotrienes are released. So now these leukotrienes will act on P50, P65 dimer, and this dimer will help in releasing all the inflammatory mediators, which will aggravate asthma, which will aggravate allergy. So what does Montelukast do? It goes and blocks this cystinyl leukotriene to P50, P65 pathway. Okay, so there is NF-K beta. Okay, so what is NF? That is nuclear factor kappa light chain B cells. The B cells are the one which are going to start secreting all these humoral antibodies and the inflammatory markers. So it has gone and put a stop there. So this Montelukast was used for this to prevent aggravation of asthma. But now we see it is the same mechanism or the same pathway COVID also is using. So we can as well use Montelukast to block that area. SARS-CoV-2 infections can lead to aggressive inflammatory response, increase in the pro-inflammatory cells, direct lung injury, and multi-organ failure. So this can lead to mortality. So this Montelukast is going and preventing the cytokine storm. Cytokine storm where interleukin-6, TNF-alpha, and all of that is released. And that is the one which causes the lung damage. So Montelukast is going and stopping that. So there is an ongoing trial. Also would like to say that Montelukast is as yet not recommended by FDA for use in COVID-19, but there have been sporadic reports and publications from across the world saying that Montelukast is protected because it has this mechanism. So 10 effects of Montelukast, this is another publication in COVID-19, is it the therapy beyond lung, okay? So in SARS-CoV virus, where we can use it, it has got antiviral properties. It reduces the endothelial inflammation and protects the blood-brain barrier. Okay. So in more than one ways, it will help in decreasing the onset of acute respiratory distress syndrome. Montelukast in hospitalized patients with this is another study where they have done a randomized controlled trial. So they've seen that Montelukast has benefited. Now coming to the next drug, that is fexofenadine, very, very commonly used. All of us are very much aware of fexofenadine. We write this drug right, left, and center for all our allergic rhinitis patients because it has a good safety profile and patients do really well with this drug. Okay, it has shown to have an impact on inflammatory mediators other than histamine. So how does fexofenadine act? It decreases the production of leukotriene, C4, D4, prostaglandins. Okay, it also inhibits cyclooxygenase and thromboxane. Very, very important. You focus on this. It limits induced nitric oxide synthase generation of nitric oxide. Now, this is a very important effect of fexofenadine. So what does nitric oxide synthase do? It will produce more nitric oxide. So why should we be bothered for nitric oxide? Nitric oxide is required, okay, but it is an important cellular signaling molecule. It helps modulate vascular tone, insulin secretion, peristalsis, angiogenesis. It's a neurotransmitter. So nitric oxide is very, very important for all the body activities. But there's a critical level for which it should be produced and how it will act as a signaling pathway. If more nitric oxide is produced, then it is the most proximate cause of septic shock. So nitric oxide in higher levels can unleash a variety of inflammatory mediators because of its cellular signaling. This can lead to sepsis and shock. Okay. So fexofenadine can decrease the production of nitric oxide to whatever it can decrease, as a result of which patient will not go into sepsis. So there have been many FDA-approved drugs which are targeting COVID-19 virus by structure-based drug repositioning. So to tackle or attack this COVID virus, we need to identify the structure. Now it has got a spike protein. It uses some protein series. Okay, so all these enzymes. We have to attack something in this virus to stop that virus from multiplying. Okay. So this is a main protease enzyme, MPRO. Okay, that has COVID-19 has got one enzyme. Through this enzyme, it will enter into two potential sites, central and terminal sites. It enters into the cells. See, this is the SARS-CoV virus. This is the ACE2 receptors in the lungs. This is the protein series of the human body. Like that, it also has got an MPRO protein. This one, it has got a MPRO enzyme, which will help it to enter the cell, and then there can be viral replication. So we have to target this protein series, MPRO. Okay. So it has been seen that fexofenadine and montelukast were the only antihistamine which were found, which could inhibit MPRO. That is the one which was used for the main protease enzyme. So it will not enter and it will not start replicating. But of course, we always have challenges with drug repurposing because a novel therapy to cure corona is far from sight. We really don't know if this drug will work. And vaccination also is a very humongous task. It increases the stress on the healthcare system. So these are all the challenges we have. So we can try safe profile drugs like montelukast, like fexofenadine, and see if it will go and stop the virus somewhere. Okay, so if it stops this protease, that replication of the virus will not happen. If replication does not happen, then the cytokine stop will not be there. Okay, so there are 5 potential targets to tackle the SARS-CoV-2 virus replication. One is the spike protein. Next one is the TMPRSS2. That is nothing but our serine protease enzyme in the human body. Then the MPRO, which is the coronavirus main protease. It is only producing this protease to enter into the cell and start replicating. So this is an interesting field of research, and it is seen that both fexofenadine and montelukast are able to tackle it at this point. So fexofenadine is known to inhibit COVID-19 main protease enzyme. More research is required to see exactly how it would work. It would demonstrate anti-inflammatory and antioxidant properties and decreases the risk of mortality. So in our hospital, by default, we're just giving montelukast with the fexofenadine combination to patients who get admitted because we feel there could be a benefit of doubt. Let them help because it's not anyway a risky drug. So these are some studies which have been done for to see if montelukast would help. So it is, but it is a known fact that montelukast causes a huge decline in the interleukins. So I would like to conclude my talk here. So the talk was basically how we handled allergic rhinitis, whether intranasal corticosteroids are safe, and about drug repurposing, how montelukast and fexofenadine are promising molecules to tackle COVID-19 virus. Okay, and more research is required, more trials are required, but this is it would be a game changer if it would work. Thank you.
Thank you, ma'am, for your insightful session. Now moving on to our next talk, that is implications of COVID-19 on respiratory health by Dr. Rajadhar. As I introduce him, allow me a few seconds to share the same with all of you. Dr. Rajadhar is a director and head of Department of Pulmonology in CK Group of Hospitals, Kolkata. He is holding a lot of authoritative positions. I'll just mention one or two. So he is the chair of training and education initiatives of Indian Chest Society and also a governing body member. He is also a governing body member of Indian Academy of Bronchology. He is a founder member of Southeast Asian Academy of Sleep Medicine. He is having 124 international and national publications in index journals and abstracts, along with 17 book chapters. He is also an abstract reviewer for for American College of Chest Physicians meeting, American Thoracic Society meeting, and European Respiratory Society 2012 till date. He is also an examiner for MRCP both in the UK and in India. He is also a coordinator for DNB course for the last 5 years, the first DNB respiratory course in Bengal. So with this introduction, I would like to hand over to you, Dr. Dhar.
Thank you very much, Meenal, for those kind words. Soumya, I enjoyed your talk. Thanks for doing that. I think that was a difficult topic and very nicely covered. Let me just bring my talk up. Right. Are the slides well visible, Meenal?
Yes, sir.
Okay, thanks, Akash. So the topic that was given to me is implications of COVID-19 on respiratory health. And I have taken the liberty of being the speaker and modified it to an extent. I will speak about respiratory health, but in continuation with Soumya's talk, I'm going to talk more about asthma as compared to respiratory health generally, because that's probably what I'll manage to do justice to in the next 25 odd minutes. So if you look at the various guidelines looking at COVID-19 in an asthmatic population, there are various world bodies which have given directives, and we'll look at some of these. So you can see GINA, you can see the BTS, you can see the Primary Care Respiratory Society, and you can see Canadian Thoracic Society. There's actually many more. The American College of Chest Physicians has come up with a guideline. And along with all that, the Indian Chest Society has come up with guidance regarding asthma during the pandemic. And this came out in Lung India not so long ago. There's various other facets of respiratory health, respiratory disease in which we have come out with guidance. And I'll also go through that as we go along. So these guidelines are more India-centric, and I was fortunate enough to be the primary author for this paper. I'll take you through certain facets of this paper, this review article that came out, and hopefully we'll manage to talk not just about asthma, but about respiratory diseases generally. So the first question, we did this in form of FAQs, and the first question we ask is, what are the general preventive measures that all asthmatics should take? And this is simple. It's about the SMS that we keep speaking about. So it's about the face mask, it's about hand sanitization, and it's about social distancing. However, there are certain facets regarding asthma which need greater emphasis. So use of the peak flow meter, because you're doing remote monitoring during the COVID pandemic for all diseases, the peak flow meter becomes a more powerful weapon when you're using it to judge whether asthma is well controlled or not. Inhalers should always be used regularly, but more so during the pandemic, because what you cannot afford, what you can ill afford, is an exacerbation during the pandemic. You live with the question, is this an asthma exacerbation? Is this a COVID-19 induced asthma exacerbation, or is this a COVID-19 pneumonia? And then your risk of mortality is going to be greater, and I'll come back to that in a moment. But it's important to make sure that your asthma remains perfectly controlled, and the most important weapon for that is to use your inhalers regularly. And then the fact that inhalers should not be shared. This again is sine qua non. It's something that's for everyone, and even during the non-pandemic era, but especially during COVID-19, you're not going to share inhalers with other people because of the risk of giving the COVID-19 infection to others. The next question we tried to answer was, how can an asthma exacerbation be differentiated from symptoms of coronavirus disease? Now, the first point to establish here is that if you get someone who's got a cough, who's got wheezing, and most importantly, a temperature, you're not going to try and spend time trying to find out whether this is COVID-19 or whether this is an asthma exacerbation. It's extremely pertinent in the middle of the pandemic to make sure that you're not dealing with COVID-19 infection or an asthma exacerbation which has been triggered by COVID-19. However, clinical parameters are important, and hence there are certain features of COVID-19 which would distinguish it from an asthma attack which has got nothing to do with a viral mediated COVID-19 mediated attack. So high temperatures, general tiredness, malaise, lethargy, anosmia, lack of taste sensation are something which are uncommon during an asthma attack. You would see that I'm using the terminology uncommon rather than unheard of, simply because you can get a COVID-19 induced asthma attack too, where these features would be indistinguishable. Just also to mention that anosmia and dysgeusia, so lack of taste, are nothing which are completely peculiar to COVID-19. You can also get it with other respiratory viruses, adenovirus, influenza virus being a case to the point. If you suspect COVID-19, then you need to follow all the COVID-19 protocols that's been discussed time and again, but it's important to reiterate them. We've said that during the pandemic, it's difficult to do investigations. When we talk about investigations here, we are talking mostly about spirometry. And I'll come back to why doing spirometry is difficult. Hence, we need to come up with tools where you can ask specific questions which will mandate a diagnosis of asthma or otherwise. And we together in the Indian Chest Society came up with a questionnaire which we feel might be helpful in trying to distinguish asthma with other diseases. So I want you to go through this chart briefly with me. So when you think of clinical features, the questions which will make asthma more likely if answered as a yes are, does the patient have any of two symptoms between wheeze, breathlessness, chest tightness, and cough? So two answers being yes makes asthma more likely. What are the symptom patterns? As in, are the symptoms more early in the morning or at night? Are these symptoms provoked by a trigger? And the triggers that we are talking about here are exercise, exposure to cold air, allergen exposure, irritant exposure, drug exposure like beta blockers, etc., and so on. Are these symptoms recurrent or seasonal? And does the person have a history of childhood allergic rhinitis or even of intermittent asthma? So again, if the symptom patterns are like this, as in early morning or nocturnal symptoms, identifiable triggers, seasonal pattern, and childhood history, asthma is going to be more likely. Now, are there certain features which makes asthma less likely? So there are features like less peak flow variability, a cough which is productive, absence of wheeze when the patient is breathless, a peak flow which is normal when the patient is symptomatic, symptoms have begun in adult life, and especially when the adult is a smoker for a while, and a peak flow variability, like we said, which is 15% over time. So less than what an asthma patient would mandate, it would make asthma less likely. So this is a broad questionnaire. It's not going to give you a score, but if you go through this questionnaire and tick them off, you're going to come up with a diagnosis in 90% of cases, which is asthma or otherwise. And I think questionnaires like this, which are validated over the future time, will be the future, because these viral pandemics will keep coming and going. One of the other things that we looked at, a different article from Lung India, as a part of an Indian Chest Society endeavor is spirometry and how would you do it? The question that arises even before that is, why is spirometry thought to be risky during the pandemic? Any procedure that's thought to be aerosol generating, that results in small droplets on which the virus can piggyback, spirometry being an example to the case, bronchoscopy, endotracheal intubation, laryngoscopy are all important examples to the case. So any aerosol generating procedure is thought to be risky. Now, if you're doing spirometry, you contaminate the environment in the room where spirometry is being carried out. But equally importantly, you're also going to contaminate the equipment. So hence, spirometry should be reserved when there's no other option. So diagnosis is impossible without doing spirometry. That's the only scenario you do spirometry. And if you have to do it, the guidelines as to how you go about doing it is on that particular article. And I would like you to read this Lung India from October 2020 to go through how you would need to do spirometry, if at all. And maybe we can answer some questions if people have questions about how to do spirometry during the pandemic. Remote monitoring, virtual consultations have been the rule. That's something we have learned during the pandemic. So how do you go about assessing asthma control during the pandemic? The various questionnaires, and there's various ways in which you can monitor asthma control during the pandemic. One of the most important asthma control tools that are available, asthma assessment tool which is available, is the asthma control test, which asks 5 common sense questions. There's a grade of 1 to 5 according to what you answer these questions as. And if you, so a maximum score of 5 into 5, 25. And if you score less than 19, your asthma is uncontrolled. Even a simpler questionnaire is the GINA symptom control assessment questionnaire. And in this, you have questions like daytime symptoms, how often, asthma-related nocturnal awakening, how often, reliever inhaler use, how often, and any activity limitation due to asthma, how often. And if you answer a yes to any of these questions, you get a 1. If you have 0, as in you say no to all these questions, then your asthma is perfectly controlled. If it's 3 to 4, then it's uncontrolled. And there are other devices, like we said, how many refills of the reliever medications, if you're using levosalbutamol or salbutamol, how many levosalbutamol or salbutamol canisters have you used in a given month, will also be a reflection of how well or how poorly your asthma is controlled. The other very important question, and this is probably the most important question in asthma, is, does inhaled corticosteroid lower the immune response and put people at risk of coronavirus disease 2019? You would have noticed that this article that I'm quoting was published in Lung India in October 2020, and the science for this has evolved since that time. Mucormycosis has come in, people are petrified of using steroids, albeit these are top parenteral steroids rather than topical or inhaled steroids that we're talking about. So we'll start off with what was established in October 2020, and then we'll go forward to what's interesting about inhaled corticosteroids, both during the COVID pandemic and in asthma. So does inhaled corticosteroid lower immune response? The answer is a big no. No evidence that inhaled corticosteroid increases the risk of getting COVID-19. And we have already said it's important to continue to take your inhaled medication in asthma during the pandemic. Very, very important, because you want to maintain optimal asthma control so that the triggers in the environment do not make your asthma control worse during the pandemic. So that's one which is established, and it was established during the first wave. What's novel? What's new? So what's new is this trial, which is the steroids in COVID-19 trial, which has been eponymously termed as the STOIC study. So this was inhaled budesonide in the treatment of early COVID-19. Mark my words there. I'm saying early COVID-19 disease. And this was a phase 2 trial, which was stopped early with recruitment of less patients because the study was found to be strongly positive on interim analysis. So the methodology, very briefly, of this study was an open label parallel group. So you had two groups of patients. One was randomized to inhale budesonide, and the other was randomized to standard care. So you could treat them the way you would treat your standard patients of mild stroke moderate COVID-19, and it had to be done within the first 7 days, ideally within the first 3 days of onset of illness. The inhaler used here was inhaled budesonide. I've highlighted the paper itself in certain parts which I think are useful. So the study got stopped, like I said, at 146 participants. They were assigned 73 patients to usual care and 73 patients to inhale budesonide. The primary outcome here was how many emergency department visits and how many episodes of hospitalization. So that's the primary outcome of the study. And I want you to see my cursor on there. So the primary outcome occurred in 11, which is 15% participants in the usual arm, and 2, that's 3% of the participants in the budesonide arm. So you've ticked the box for primary outcome and ticked it strongly. This is a very strong p-value that the number of emergency department visits and the number of hospitalizations reduce greatly when you are on inhaled budesonide early in the course of mild COVID illness as compared to the other arm, which was the standard of care arm. The next question, the secondary outcomes for this study was that, does this drug reduce the duration of the disease? And it showed that the total duration of the disease was shortened by a day. So in the inhaled budesonide arm, there was 7 days as the duration of illness, whereas the standard of care arm, it was 8 days as the total duration of illness. What about the most important symptom of this disease? What about fever? The mean proportion of days with fever in the first 14 days was lower in the budesonide group as compared to what it was in the standard of care group. So let's get this straight in our head. What are the 3 things that we are targeting with inhaled budesonide, be it in asthmatics with COVID-19 or be it just in COVID-19? This is a study which looks at all of COVID, but it's got important implications even in asthma. So in the standard of care arm, you have greater number of hospitalizations and emergency room visits. You have greater duration of disease by a day, and you have more fever. What are the secondary endpoints where there was no difference? The 2 endpoints where there was no difference between standard of care arm and the budesonide arm was that saturations did not seem to get affected, and the cycle threshold, which was a reflection of the viral load in these individuals, was not reduced in the inhaled budesonide arm when compared with the standard of care arm. So at least in this study with small numbers, and I say this because I think the viral replication does reduce with inhaled steroids. However, in this study, we found that the saturations did not alter and the viral load did not get altered when you took inhaled budesonide compared to the standard of care arm. We'll know more about this study. This is the multi-center study from India, for which I am the primary investigator, which is STOIC2. The study is funded by Oxford itself, and we have completed inclusion, and we're looking at the stats. And watch this space. Hopefully, I'll have more information about the STOIC2 study from India for all of you very soon. The next question that gets asked is, what about nebulization during the pandemic? Again, there's guidance from the Indian Chest Society. And again, if this is an area which interests you, please read this article, which is first authored by Dr. Rajesh Swarnakar, the Secretary of the Indian Chest Society. This is ICS guidance for nebulization during the COVID-19 pandemic. Suffice to say that nebulization itself does not generate aerosols from the patient. It generates aerosols from the machine. However, there's a patient attached to the machine, and when the patient coughs or breathes deeply, you will generate aerosols which get mixed with the aerosols that are being generated by the equipment, by the nebulizer machine. And hence nebulization, if required, if has to be done, needs to be done with utmost care in rooms which are closed, in rooms where there are other inhabitants, other patients, and otherwise an MDI with a spacer is the way forward during a pandemic. That's the brief of it, but there are far greater details, much better look at evidence if you read through this article. How do you manage acute symptoms at home. A written action plan is something that's been spoken about regarding asthma for a very long time. And a written action plan is when there's a flare-up of the disease. A written action plan should tell people how to recognize their symptoms, when to ring alarm bells and say, okay, my disease is out of control, I need to implement this written action plan, when to increase the dose of the medications, when to contact your doctor, how to monitor peak flow readings, and how to go about taking your first dose of steroid when your disease becomes out of control. So that's about a written action plan. And again, if there are questions during the question and answer session, I would be happy to answer them. Is it advisable to use oral corticosteroids for asthma attack during the pandemic? The answer is, unlike inhaled steroids, oral corticosteroids taken early on in the course of the disease, of the COVID-19 disease process, does increase viral replication and increase the viral load. Hence, if you get an asthma attack, you need to take the steroid, but ensure two things. First, it should not be taken for a long time. The number of days ideally should be 5 days, or it should be as short as possible. And second, you need to maintain the lowest possible effective dose, which is ballpark somewhere around 0.5 milligram per kg for prednisolone on a daily basis. The other question in the asthma field that gets asked is, what do you do with biologics in asthma? An important answer to that question, if you have severe asthma and if you're on biologics, you should continue on the biologics and you should not discontinue them. However, if you're thinking of starting biologics new in patients with asthma, you would probably want to wait till the peak of the pandemic is gone. This is not based on evidence, but on common sense. A drug which has got widespread implications, might have implications on immunity, is better started when you're post the pandemic. In the last 5 minutes of my talk, I'll talk a little bit about the GINA guidance and what it says in its updated guidance. The updated guidance is now about 3 months old. So what does GINA say, which is different from what we have said in the Indian Chest Society document? First, what about increased risk of COVID-19 or severe COVID-19 in people who suffer from asthma? So very important point here, people with asthma do not appear to be at an increased risk of acquiring COVID-19. This is based on reasonably robust evidence. There are systematic reviews that patients with well-controlled mild to moderate asthma do not have an increased risk of COVID-19. And I said, do not have an increased risk. Are people with asthma at increased risk of COVID-19 related deaths? And again, if your asthma is well controlled, mark my words, well controlled asthma, you're not at an increased risk of COVID-19 related deaths. However, the risk of COVID-19 death was increased in people who had recent courses of oral corticosteroids for their asthma, or if you're hospitalized with severe asthma and happen to have COVID-19, your chances of mortality is going to be greater. And this is a very recent paper from Lancet Respiratory Medicine. What are the implications for asthma management? So it's important to continue good asthma management with strategies to maintain good asthma control, which reduces the risk of exacerbations. And has there been more exacerbations during the pandemic? And this is a very interesting, very intriguing question. There's actually been less asthma exacerbations throughout the globe as compared to what there has been in the previous 10 years anywhere in the world. And this is data that's been looked at by various international global bodies. And people don't know why that is. Is it something that asthma does to the immune system? Or is it because of the general health measures, the COVID appropriate behavior that we keep talking about, the hand washing, the masking, and the social distancing, which is responsible for less exacerbations? However, we're not complaining. We are happy that asthma exacerbations seem to be less during the pandemic. What do you do with prescribed medications and inhaled corticosteroids? We've said that they have to continue, and that's a no-brainer. Are ICS protective in COVID-19? And we've said that's a yes. We have said that this on the basis of the STOIC study, and hopefully we'll say that on the basis of the Indian STOIC 2 study, for which we are awaiting results. Written action plan is a big yes. Avoid nebulization is something that we have spoken about, and again, has been emphasized in the GINA guidance. We've spoken about aerosol generation from spirometry and the fact that if you have an option, you would use questionnaires, you would use quality of life indices like the ACT questionnaire and the GINA control guidance in trying to assess control of asthma rather than using spirometry. Infection control policies need to be strict. Nebulization, sputum induction, manual ventilation, non-invasive ventilation, all need to be done with perfect personal protective equipment and with the least number of people around at a risk of acquiring the infection. What about vaccination? You're going to hear an entire talk about vaccination in a minute, but has COVID-19 vaccine been studied in people with asthma? The answer is yes. Various vaccine has been studied. There's new evidence that's emerging about vaccination in the asthma population, but the bottom line is that COVID-19 vaccination is not only safe, it's something that needs to be done in the asthmatic population. What about people with allergies? The data about the Pfizer and the Moderna vaccine is emerging. The recommendation is that it should be administered in a healthcare setting where, God forbid, if this anaphylaxis be treated appropriately. There's no such warning about the other vaccines that are available, especially in India. The vaccine should not be administered to people with a history of severe allergic reaction to polyethylene glycol, which is a vaccine ingredient. And patients should speak to the healthcare provider. You should actually get your concerns addressed in case you have any concerns about vaccination. But a big tick, remember, about vaccination, it should be done to everyone other than very exceptional circumstances. A question should be asked as to whether there's a history of allergy to any component of the vaccine. And based on risk and benefit, like we have said, GINA says a big yes to vaccination during the pandemic. We have spoken about biologic therapy. The other important factor is, unlike places like the US, where vaccination seems to set you free, it's almost a freedom tick. You go around without masking, without sanitization, etc. The rest of the world, including the US, the CDC, very strongly recommend that even if you're fully vaccinated against COVID-19, you should continue to wear a mask in crowded settings. And the fact that annual influenza vaccination and pneumonia vaccination, as indicated, should go on even during the COVID-19 pandemic. That's a very strong message again from me. Don't forget the influenza vaccine. Don't forget the pneumonia vaccine as is appropriate. So my concluding remarks for that talk is that asthma does not increase the risk of COVID-19 infections. ICS has a protective effect, not just in asthmatics, but even in non-asthmatics early on in the process of COVID-19 infection. Vaccines are safe in asthma in a majority of cases. That's a vast majority, 99% of the cases as an arbitrary number. Monitoring of asthma now needs to be more symptom-based rather than lung function-based, spirometry-based, because lung function testing is an aerosol-generating process, and even other aerosol-generating processes like nebulization, sputum induction needs to be done with utmost caution, if at all, in patients who are during the pandemic. So thank you very much for listening. I hope I have finished my talk on time. Thank you very much.
Absolutely, sir. So thank you very much for your wonderful talk. I'm sure many of the doubts are already cleared with your session itself. Also, you have told many new things which are not covered at many sessions which we hear these days. So thank you very much for this, sir. Now, moving on to our next talk, that is safe implementation of vaccines to manage COVID-19 pandemic by Dr. N.K. Soni. I will just share my screen and introduce him to all of you. Dr. N.K. Soni is a Vice President of API National Body. He is a past President of UP Diabetic Association, and he was also a past Chairman of RSSDI UP chapter. He is a past President of Indian Association of Clinical Medicine and a Principal Guide for DNB Internal Medicine. He is a regional faculty at Public Health Foundation He is having multiple publications and more than 20 chapters. He is also having articles in various books and various journals, which we have already seen. I'm sure all of us are already aware about this. Now, I would just like to hand over the session to Dr. Soni. Over to you, sir.
Thank you. Thank you very much for a nice introduction, Dr. Meenal. If I share my slides first. I'm sorry. Yeah. Well, after listening to wonderful two talks by Dr. Soumya and Dr. Rajadhar, who spoke very well about all the aspects, clinical aspects of respiratory diseases, asthma, ENT, allergic rhinitis, and the association of COVID infections and how to treat and how to diagnose. Wonderful talk by Dr. Rajadhar, and has cleared many doubts whether asthmatics should be given, how asthmatics should be differentiated for having the COVID infection. And this is really a huge task and difficult problems which most of us clinicians, they face in our day-to-day clinical practice. Well, we must agree that this pandemic of COVID-19 has changed the life, the clinical practice, the attitude, the thought process, and has affected the general population to a very large extent. And in the coming years, when we will remember this pandemic, probably in the coming years, we'll remember this pandemic in three phases of BC, DC, and AC, that before COVID, during COVID, and after COVID. And of course, we are running in this period of DC, that is during COVID period. And in this COVID period, we all know that this is a new disease process, as Dr. Soumya has said, and we do not know a specific treatment as far as the COVID infection is concerned. So naturally, as again Dr. Rajadhar has said, that we have got 4 steps where we can prevent or we can control this pandemic infection to a large extent. The one is hand sanitization, we all know. The second is, of course, putting the mask, and the masks to be put in covering the mouth and the nose and not on the chin, which we see quite often in our population. The third is, of course, social distancing. And fourth, most important one, is the vaccination. That is true that vaccination cannot prevent the disease process. But yes, definitely in the last 1.5 years, as we are facing this pandemic, we have realized that vaccination can, of course, decrease the intensity and severity of the illness, can decrease the morbidity to a large extent, can decrease the mortality also, and the chances of hospitalization are also reduced significantly. So vaccination plays a very, very important part as far as the management and prevention of COVID-19 pandemic is concerned. And this is what I'm going to discuss in the next 15-20 minutes. My talk will be a little shorter than what the talk was for my previous speakers. Well, after the passage of 1.5 years, when the corona infection was first detected in China's Wuhan province, the efforts were initially concentrated on preventing and slowing down the transmission. But then the global analysis of herd immunity in COVID-19 has shown the urgent need for efficacious COVID-19 vaccination program. And currently, the vaccine development efforts have started to bear the fruit, as some of the leading vaccine candidates have shown the positive results in at least controlling the severity of the illness. Well, if you go through the landscape of COVID-19 vaccines which are under development, India has got a very robust facilities for the development of vaccines, not only for our own country, large, huge population of 139 million population, but also is able to export to the other developing nations who are not able to afford those vaccines from the Western world. And out of all these 8 or 9 vaccines which are in the various stages of the developments, at present, the 3 vaccines which are available for the vaccination programs in India are, one is the Covishield, which is developed by Serum Institute of India, that is actually developed by AstraZeneca, but is produced by Serum Institute of India, Pune, in collaboration with AstraZeneca. The second indigenous vaccine is Covaxin, which is developed by Bharat Biotech International Limited, Hyderabad, in collaboration with ICMR. And the third vaccine, which is recently been available in India, is Sputnik 5. It's a human adenovirus vaccine, which is trialed and manufactured in India by Dr. Reddy's lab. And actually it was developed by the National Epidemiological Center, Russia. So these 3 vaccines are already available for the vaccination of Indian population. The other vaccines which are in the pipeline in the various stages of the development, as well as their trial programs which are going on, are one by Zydus Cadila of Zycov-D, which is a DNA vaccine, and the other is again by Biological Events Limited, Hyderabad, which is again a recombinant protein antigen-based vaccine, again in the phase 1 and phase 2 clinical trials, as well as by Aurobindo Pharma. Even Bharat Biotech International Limited is also having another inactivated rabies vector platform vaccine, as well as Serum Institute of India, Pune, is also developing another vaccine with the collaboration of Novavax from US. So all these vaccination programs, they are being developed and being monitored by Government of India. There is a huge logistic issues of vaccinating the population in general, and thus the government has issued the guidelines for voluntary vaccination programs and has encouraged by various medias and various measures, various methods to encourage the people to take this vaccination on a large number. So if we discuss about these vaccinations which are available, you'll see the first is the Covishield, which was made available for the Indian population. The Covishield in various studies abroad and in India has shown the safety as well as immunogenicity and effective data. In the UK, it was studied in large number of population with the large dose of the virus particles, which were injected in the population of more than 18 years and has shown the efficacy to the tune of around more than 70%. Even the Indian vaccine, which was developed by Serum Institute of India, it has shown the safety and immunogenicity data which were generated in the clinical trials in India and has found to be comparable with the global data. So these Indian vaccines of Covishield manufactured by Serum Institute has also found to be the same efficacious as it was found to be by Oxford AstraZeneca vaccine. The second vaccine, which was developed by Bharat Biotech and was an Indian first domestic vaccine, is Covaxin. The Covaxin in the clinical trials were conducted for more than 800 subjects, and the data have been published. The results have shown the vaccine is safe and provides a robust immune response and protection. In phase 3 efficacious trial, which was initiated on more than 25,000 volunteers and more than 22,500 participants have been vaccinated across the country as per the current evidence. And it has also shown that the vaccine is safe and efficacious to a large population altogether. The third vaccine, which is available in India for the vaccination program, it is the Sputnik 5, Sputnik V. It is a registered vaccine based on well-studied human adenoviral vector-based platform. So that is one vaccine which is on studied human adenoviral vector, and it is already registered in more than 65 countries. The post-registration clinical trials in Russia of Sputnik V vaccine have involved more than 31,000 volunteers, a large population. Phase 3 clinical trials have been conducted in various countries, including United Arab Emirates, India, Venezuela, and Belarus, in various countries all over the world. The Sputnik V is one of the 3 vaccines in the world with the efficacy of more than 90%. So almost you will see that all the 3 vaccines have got the efficacy between 70% to 90%. And all the 3 vaccines are efficacious. The vaccine efficacy is confirmed to the tune of around 91% based on the analysis data of around 20,000 volunteers who received both first and second dose of Sputnik V vaccine or placebo at the control point of 78 confirmed COVID-19 cases. So all the 3 vaccines have found to be safe and efficacious in large population. And as my previous speakers have emphasized, that all those cases of allergic rhinitis or bronchial asthma, if the disease process is well controlled, they should be vaccinated, and they should get the vaccine so that the morbidity and mortality because of the COVID infection is decreased considerably. It has also been shown that the technology which is being used for the licensing of agreement, it has used other as the solutions for the efficacious effects of the vaccines. It has shown that these vaccines, they also help in sensitizing the CD4 T cells, which remember the antigenicity of the virus, and thus they get the immune response because of these vaccines for a longer period of time. And as far as the dose schedule of various vaccines is concerned, the Covishield, there are little confusions about the dose schedule between the 2 dosage which are recommended to develop the adequate response and antibody response from these vaccines. so that a person is immunized and protected from the seriousness of the infection from the COVID, this virus. For Covishield, the time interval between the two dosage has been extended from 4 to 8 weeks to, it has been said that about a 12 to 16 weeks interval, if it is taken between the two dosage, probably the response and the protectiveness and the development of the antibodies and the sensitization of CD4 T cells is a little more intense, more powerful, and gives some more protection and long-term protection against the viral infection by giving the extended interval between the two dosage. While for Covaxin, still in the second dose, it has been recommended that the second dose should be taken 4 to 6 weeks after the first dose to develop the immunogenic response. Similarly, for Sputnik V, the 2 doses interval has been recommended by the guidelines to the tune of around 21 days. So it can be taken after between this is the interval between the 2 dosage to initiate to develop the immune response. And as we have all seen that for safe implementation of the vaccine programs, there has been various guidelines, and the government of India has taken the responsibility of controlling all the guidelines and implementing the vaccination programs all over the country. The government of India has constituted a national expert group on vaccination administration for COVID-19. That's the NEGVAC group, which consists of various ministries, more than 23 ministries with various officers, as well as the experts from the pulmonologist, oncologist, nephrologist, cardiologist, as well as the other groups as the part of this group, who provide the guidance on all aspects of COVID-19 vaccination administration in India, that who are the priority groups, who should be given the vaccine first, and the other population with the comorbidities, who should be preferred for the vaccination programs, and that is how this is monitored. The CoWIN app, which is the COVID-19 Vaccine Intelligence Network, is a comprehensive cloud-based IT solution which is used for planning, implementation, monitoring, as well as evaluation of COVID-19 vaccination in India. A person can pre-register on this CoWIN app, and then he can search for any center nearby where he can go for the vaccination, and then he can get the certificate of vaccination on this app. The Indian government has taken urgent measures to expand the country's vaccine manufacturing capacity and has also developed an efficient digital system to address and monitor all the aspects of vaccination administration. And we must agree that it's a huge, very horrendous task to vaccinate huge population of 138, 139 million population in India. And so that the sooner the herd immunity and the vaccination program is successful, less are the chances of serious COVID infections and morbidity and mortality, which has caused a lot of effect, not only socially, financially, economically, even the mentally also in a large population as such. The key elements of the communication strategy for the vaccination programs are based on the learning of National Immunization Campaign, and 5 key elements of COVID-19 vaccination communication strategy have been developed to support the rollout of the COVID-19 vaccine at the national level as well as at the state level. So at the 3-tier levels, this program is going on from the national to state to the district level, and thus the community-based programs are also going on largely in our country. The 5 key elements of successful vaccination program for the vaccination communication strategy are: one is the advocacy, where we have to advertise, we have to convince the patient to go for the vaccination as it is a voluntary vaccination program. The capacity building, that we have to see that the people, they are comfortable in going to the centers for the vaccination. Media engagement and social media advertisements, social mobilization and community engagement, which is a very, very important aspect in building up the confidence of the society in getting the vaccination done. And then the adverse effect following immunization crisis communication. So these are the 5 aspects that if these are managed effectively, then at least any vaccination program can succeed. So COVID-19 vaccine eagerness, trust, and development of the confidence is of prime importance for the successful program development. The safe vaccination and addressing the public concerns. Of course, the allergists, ENT experts, the pulmonologists, clinicians, physicians, they have got the role, very important role. The allergist expertise in diagnosis and treatment of allergic reaction is valuable for screening of the individuals, training of the clinical staff conducting the vaccination programs, as well as the management of the patients who experience potentially allergic reaction to COVID-19 vaccines. Although the chances of development of allergic reactions are very minimal, even 0.001 or 0.01, but still, whatever may be the chances, they should be tackled with by clinical staff effectively, so that the people, they develop the confidence to go for the vaccination to a large extent. And this is carried out through a self-reported answers to the questionnaire, which should be given to the patients by telemedicine visits or with an allergic clinicians for a high-risk patients prior to the first vaccination dose or after the potential allergic reaction to the first dose. It enables the clinicians phenotype, risk stratification, reassurance to the patients deemed at the lower risk. And the CDC guidelines, they also emphasize at least 15 minutes to half an hour, the 30 minutes observation after all the dosage or the appropriate medical treatment for allergic reactions. The allergist can help reassure the patients and educate, provided by the addressing a few issues. They should educate the patients on the diagnosis and treatment, on the anaphylaxis. Even the staff should also be trained, providing at the elbow support for the vaccination programs, that whenever any adverse reaction occurs, it should be managed promptly and safely, providing support to the individuals with benign symptoms after the discharge and after the vaccination, and then we can provide them the support to the telemedicine. Even the American College of Allergy, Asthma and Immunology, they have given the guidelines for the vaccination of allergy and asthma patients, but this has already been discussed in detail by Dr. Soumya and Dr. Rajadhar, that asthma, there is no data to suggest any major degree of weakening or of immune system due to inhaled corticosteroids, as has already been emphasized upon. So there is no contraindication to receiving the COVID-19 vaccines while on the inhaled corticosteroids. Similarly, for allergic rhinitis also, there is no contraindication in receiving the COVID-19 vaccines if the allergic rhinitis is well controlled, even with inhaled corticosteroids and other anti-allergic and montelukast, as already been described. So the risk stratifications might last 2 slides. That risk stratification pathway before the initial COVID-19 vaccination, we should give the questionnaire. We should ask the patient to reply these questions, that do they have any history of severe allergic reaction to an injectable medication? Do they have a history of allergic reaction to a prior vaccine, or any allergic reaction to another allergen, or even the other solutions like polyethylene glycol or polyoxol, castor oil, etc., which are there as absorbent in the injectables or in vaccines. If the answer is yes to the questions, then question number 4, then at least the patient is considered, the person is considered to be at higher risk for the allergic reaction. He should be observed very closely. History of potential anaphylaxis should be taken. History, even history through the potential anaphylaxis to oral PEG also should be taken. Clinical phenotyping and expanding skin testing should be done. But if the answer is yes to first, second, and third questionnaire, then the person is considered to be at the medium risk of developing the allergic reaction. The routine vaccination should be done with 30 minutes observation. And if there is no to all the 4 questionnaires before vaccination, then the person is considered to be at the lower risk. And routinely after vaccination, at least minimum 15 to 20 minutes should be the time for the observation of an individual, and only then it should be sent home. The history of food allergy or any other allergy or allergic rhinitis and asthma or the disease process should be taken, and should be seen whether these symptoms are adequately managed prior to the vaccination program or not. Similarly, there is stratification after allergic reactions. Those were before and these are after. It has been seen that the history of the vital signs, physical examination, laboratory test, treatment recovery, this should be taken after allergic reaction to the first dose it has occurred. And those patients with the potential anaphylaxis to the first dose of vaccines who are at the higher risk may be ineligible for second dose, and they should not be given a second dose. Shared decision making for the second dose in unconfirmed anaphylaxis with a negative skin testing only. So first skin testing should be done, and then only the second dose should be given. Those patients who are at the medium risk should be given again for clinical phenotyping, and again their shared decision making should be taken. They should be explained the risk of vaccination clearly and consider the vaccination with 30 minutes observation with the patients on the lower risk with the large local reactions only, non-allergic signs and symptoms, subjective symptoms which most of the patients they get. They only need a little reassurance, and the second dose can be given, and they should be asked for the observation for at least 15 to 30 minutes and then only. But then most of the patients, they develop little local reaction at the injection site, which subsides subsequently in a day or two, and there are some subjective symptoms of weakness or headache or giddiness which goes with the reassurance and observation. But then whatever may be the chances are almost negligible, but still the anaphylaxis should always be kept in mind as far as the serious reaction which can occur with the vaccinations, and the graphic assistance to recognition of anaphylaxis should be done with the skin and mucosa pruritus, respiratory compromise if the patient develops dyspnea, breathlessness, decrease in the peak expiratory flow, stridor or a hypoxemia, even the hemodynamically if the patient is unstable. These are the severe signs, symptoms of anaphylaxis which can occur Similarly, the milder symptoms, moderate symptoms, which can also occur or the anaphylactic symptoms, then anaphylaxis, we must always keep in mind, is a life-threatening hypersensitivity reaction, which can occur either to the vaccine or the absorbent, which is added to the vaccines, and hypersensitivity reaction where rapid early administration of the drug, hospitalization of the patient is crucial for the recovery. So these are the guidelines, these are the vaccination programs which are being carried out. The purpose of this perspective was to highlight the overall crux of the vaccine development and vaccine strategies that were implemented during the pandemic in a densely populated country like India. The report, all these data can be viewed as a baseline document for future pandemic preparedness and effective trailer and refine the strategies that will help the population at large. The current COVID-19 pandemic has triggered rapid development, emergency use authorization, and unprecedented collaboration efforts from the various stakeholders who are developing the vaccine for decreasing the morbidity and mortality of this virus infection. Although vaccination might be a cost-effective strategy for the survival, but a better quality of life for the people as well as for the revival of the economy, the question remains for many of these effects and the side effects of the vaccines. For example, vaccines might not work for some individuals. There is an individual variation for the development of antibodies and the protective response, and thus in turn requires a periodic re-evaluation of the vaccination program. Owing to these barriers, the gaps must be filled, and global coordination and the sharing, transparent sharing of the knowledge and studies should be encouraged in various countries, among the various countries, for developing a robust and effective vaccination program so that we can provide a good quality of life to our population. With this, I would like to thank all of you for your patient listening. Thank you very much. Yes, Meenal, for you.
Yeah, sure. Thank you very much, sir. It was a wonderful talk again. There were many questions already there for the vaccination part, and I guess many of them are already answered with your presentation. Thank you very much. So now with this, we are done with all of our three talks. So thank you very much, Dr. Soni, Dr. Dhar, and Dr. Samya for such insightful sessions. Every presentation has been enlightening. Now, as leaders in allergy management, Sanofi has always been at the forefront to bring innovative allergy management solutions for our patients. Before we move into our very interesting panel discussion and address the audience Q&A, I want to take this moment to announce to all our connected doctors about the latest innovative product from Sanofi Allegra portfolio, that is Allegra Nasal Duo, which is a smart spray of azelastine and fluticasone furoate, tactfully developed to provide superior patient experience for managing allergies, while addressing the biggest concern in azelastine therapy, which is a poor taste of this molecule. So allow me to take a minute to introduce this new product. Over to you, technical team. Can we please have a video?
There are some dangers that are invisible to the naked eye, and they in building innovative solutions. We are now ready to take on the future. In the era of digital transformation and smart solutions, why should your nasal spray be any different? Introducing a smart therapy, Allegra Nasal Duo. With modern APIs, azelastine, the fastest acting topical antihistamine coupled with fluticasone furoate, the modern generation intranasal corticosteroid with sustained 24-hour action. There were challenges and needs to be addressed, and we did just that. When one of the biggest challenges to address in the therapy was the non-compliance due to the bad taste, we worked on the smart taste masking mechanism enabled by Neotame, that is 20 times superior to the traditionally sucralose masked nasal sprays. When the need was stable delivery of the drug in the nasal mucosa, we delivered the smart partnership with uniform suspension technology. When the need was to design a smart device, we sculpted a smart device engineered with German expertise for the perfect spray delivery in the nasal mucosa. And finally, when patient education and compliance was a concern, we developed a first-in-class smart packaging to drive patient compliance. Allegra Nasal Duo, launching the smart spray that is designed to deliver superior quality, ensure compliance and produce better patient outcome.
Thank you very much. So now with this, we would like to start our panel discussion. So technical team, can we please have all of our panelists?
Yeah.
Okay, great.
Mhm.
So we have already received a lot of questions from audience. So we will start with our first question. This question is to Dr. Soni.
Okay.
Sir, how has management of allergies changed during this pandemic according to your practice?
Management of allergies, the symptoms are most of the time they are overlapping, as it has already been discussed by Dr. Soumya and Dr. Ajadhar, that the patients whenever they come with the nasal blockade, with cough, with fever, with the other symptoms which are common as far as the allergic rhinitis are concerned, which are with the COVID as well. So it becomes a little difficult to differentiate between the two, but then the management, at least it remains almost the same, that we have to use the anti-allergies, we have to use the Montelukast combination, as it has been proven and it has been shown by Dr. Soumya in her presentation, that definitely we have also observed that in allergy or allergic rhinitis, the combination of anti-allergic with Montelukast, using it for a longer period of time, it does help in controlling the symptoms to a large extent. And the same procedure goes on even during the COVID period also. And whatever steroids, intranasal steroids, if they are using it, of course, it does help along with the supportive therapy of cough syrups and others.
Right. Okay. Sure, sir. Thank you very much. Now, moving to Dr. Rajadhar. So there is this little generic question, but I guess this is asked 3 times. What are the common exercises for preventing airway disease?
So I think I'll take the question in continuation with what Dr. Soni said. So I think what's been different during the COVID times is likely because of the sanitization, masking, etc. The triggers, be it for allergic rhinitis or be it for asthma, has generally been lesser. And hence we've seen less flare-ups of the disease, at least in the asthma category. Soumya can correct me if it's different in the allergic rhinitis category. But at least in the asthma category, throughout 2020, we have seen about a 40% reduction in the number of exacerbations, be that mild to moderate exacerbations, and even lower for severe exacerbations across the board, right? And I think if you use your inhaled corticosteroids wisely, patients with asthma on inhaled corticosteroids seem to be relatively protected against the disease process as compared to what it has been outside the pandemic. The management, I think, is very, very similar. Intranasal corticosteroids for allergic rhinitis, inhaled corticosteroids for asthma form the backbone. And then there is the anti-allergics that everyone has spoken about, which are very, very pertinent in controlling the disease process. I don't know whether, Meenal, I lost track and did not answer your question. So tell me what again the question was, whether it was different to what I said.
So, sir, are there any specific exercises which we should recommend patients, or you are already recommending patients to prevent airway diseases in this pandemic?
So I don't think there's exercises, Meenal, which would actually prevent exacerbations. The protective measures, avoidance of triggers, rehab is something. So pulmonary rehabilitation is something that we've spoken time and again during the pandemic, especially post-COVID. But I don't think there's any exercise. I can see Dr. Soni's hand. Maybe there's something that you want to add.
Yeah, Dr. Dhar, my specific question, probably the audience would also like to listen from you, is that in post-COVID period, when there is a lung involvement to a great extent, during that period, what exercises, the common exercises for the airway disease is recommended, as Dr. Soumya is also raising her hand. So,
yeah.
So
I'll let the lady answer first. I understand, Dr. Soni.
Yeah.
I understand.
Any restriction of the exercise?
The lady answer first, and then I'll have a go.
Okay.
Raja, actually, we did one interesting study on certain set of hatha yogasanas and allergic rhinitis. So, for ages, it's been told yoga is very good and all that, but we wanted some objective evidence. So we put the patients, did a randomized control trial, put them in 2 separate groups. And then we made them do a particular set of exercises, and we did a rhinomanometry and pulmonary function test. We saw that people in the yoga group had better benefit. I mean, they had better control of their allergic rhinitis symptoms and their asthma. So we saw that there was decrease in the nasal resistance and airflow was improved. So and it was statistically significant. The study was statistically significant also. Maybe it could help, just like, we give those, the pulmonary function to improve, we give those balls and we ask them to blow it, which we do on a bedside, like that, pranayamas and all that the patients can do and might be benefited.
Sure. So fair point. I think I'll take what you said, Soumya, along with Dr. Soni's question and try and answer. So I think any exercise, any form of pranayama, yoga, this is Dr. Randeep Guleria's large study looking at the role of yoga in patients with COPD, for instance, and other chronic lung diseases, which has shown a significant improvement of exercise tolerance in patients who've got severe chronic lung disease. Now, whether it's the allergy component which is getting controlled because of these maneuvers, or whether it's the general fitness of the individual, improvement of the respiratory muscles, upper limb muscles, lower limb muscles, which are getting affected, where we get a benefit, is, I think, open to debate even today. However, I don't think it matters at the end of the day. I don't think it matters whether it's the allergy component which gets better control or whether it's just general fitness which gets improved. The bottom line remains that things like pranayama, yoga, along with the more conventional pulmonary rehabilitation during the post-COVID period, which seems to have the most marked benefit. The drugs that we have in the post-COVID period, be that the antifibrotic, be that the prolonged course of reducing dose of steroids, all of them are open to controversy and the jury is out as to whether they help or not. Where the jury is not out, but I think there is a definite answer, is the fact that planned rehab, home rehab, maybe with virtual monitoring, is something which helps a lot during the post-COVID period. And I think Dr. Soni's point is very pertinent. One of the things that we often forget to do, and which is most evidence-based, is to give prescription exercises, maybe amalgamating things like yoga, etc., into the prescription and ask people to do these at home if you want people to recover from the post-COVID lethargy, fatigue, tiredness, breathlessness that patients with severe COVID have.
So it's an excellent exercise to improve the lung volumes. But with the COVID scenario pandemic, swimming pools are closed and all that. So I think some simple yoga at home would be good.
Probably the spirometry, there is 3-column spirometry, which we advise for most of the patients to do, and how vigorously it should be implemented. And that is the doctored program which we should give to these patients, because we have seen that the patient has recovers from the COVID, but suddenly he pops off and he develops pneumomediastinum, pneumothorax, and others. So how vigorously it should be done in the spirometry and others in the post-COVID period? That was the point.
So, Meenal, just one quick point. I know you've got plenty of questions to ask. I can see our very senior colleague, Dr. Ruby Pavankar, has put in lots of questions in the question box. So we'll come to them in a minute. But just to reiterate Dr. Soni's point,
Sure.
Incentive spirometry is a good exercise for most patients in chronic respiratory disease. And the underline there is in the word most rather than all. And the reason is what he very eloquently pointed out just now. If in patients who've got severe chronic lung disease, interstitial lung disease where there's honeycombing, etc., and if you ask them to do incentive spirometry, the chances of pneumothorax and pneumomediastinum go up considerably. So it's not a one size fits all. It's not as if you ask everyone to do incentive spirometry. You ask 90% of people to do it. However, there's a small percentage where you actually ask them not to do incentive spirometry because they could come to harm doing this exercise rather than having a benefit from doing it.
Sure, sir.
Yeah.
Sure.
True.
Yeah. Thank you very much, everyone, for adding your points in this discussion. I guess it was very clear after that. So as Dr. Raja has already mentioned, we have questions from Dr. Ruby. Thank you very much, ma'am, for joining this session. She has been a pioneer in the field of allergy and UAD management. So I would just quickly take this question to you, Raja sir. She's saying that asthma and AR are not comorbidities of COVID-19, and this has been shown. Also, all of you yourselves have done a survey, it seems, where the hypothesis was being a variety of factors, including high Th2, leading to low ACE2 receptor expression. The data across Asian countries is very similar to US and Europe. So has this been pattern changed with the new Delta variant?
So Ruby, thanks for that question. We're grateful that you've actually joined the session. So a couple of things. I actually showed the Apache paper that I was fortunate to be a part of as one of my first slides, my second slide for the presentation. I don't think the pattern has changed at all. We feel that allergic rhinitis and asthma are not really comorbidities in the way that people with these disorders have an increased risk of getting COVID-19, nor do they seem to have more severe disease. So it's not a comorbidity. As far as the Delta variant disease is concerned, the only data that's got published till date, to the best of my knowledge, is from the UK. And I don't think the allergic rhinitis asthma non-comorbidity aspect, not being a comorbidity aspect, is something which is different in the Delta variant or the Delta plus variant, but it's limited. If memory serves me right, the data is with about 5,500 patients. That's all the data we have. ICMR will come up with the Delta plus and the Delta variant data. I suspect the data would not be very different because I don't think the pathophysiology of the disease is going to be very different, even with the mutant strains that we have on board today.
Right. Okay. Okay, thank you very much, sir. So now moving to a second question, which Dr. Ruby has asked to Dr. Soni.
Yes.
So, sir, Apache guidelines are developed based on CDC, and those are available in the public domain. And they do recommend the pre-medication for those with a history of anaphylaxis to foods or PFAS, which is H1 or H2 blocker, and Montelukast 30 minutes prior. Do you advise the same?
Yes, I do agree that we should give a questionnaire to these patients, and if there is a significant history of allergic or anaphylaxis to these compounds, we know that vaccination is a process, is usually the preventive measure which can decrease the morbidity and mortality because of the COVID infection. That is the most effective measure. So we should always encourage that. And if there is a history of allergy, of course, we should give these medications like Montelukast and other medications, which can be given at least half an hour prior to that. And we fully agree with Apache guidelines, which have been published, so that it can prevent. But still, these patients should be taken in a hospital setup with all the facilities which are available to deal with any eventuality of developing anaphylaxis, and should be managed properly. Yes, Dr. Raja, he was raising the
No, I think you said what I wanted to say, Dr. Soni. I think the ICMR guidance, even the guidance from the ICS is that if you have known anaphylaxis, and I think often people confuse the term anaphylaxis and having a side effect, a perceived side effect like a diarrhea or an abdominal pain or a bit of rash from anaphylaxis. So anaphylaxis in the proper sense of the word, vaccination has to be thought about. That's one scenario, small scenario, when you need to think twice about vaccinating. It needs to be in a safe place, like Dr. Soni said. And I think while we would recommend using anti-allergics in this scenario, we don't have Indian guidance for it. Hence, I think there should be a proper discussion with the patient. The pros and cons should be discussed, the risk factor discussed with the patient before you administer the vaccine to these patients who have had prior anaphylaxis. Whatever the agent might be, anaphylaxis is something to be cautious of, I think.
Sure. Thank you very much, sir. Now, this next question is to Dr. Soumya. So, ma'am, how long it will take for COVID changes in lung to recover, according to your practice? And then we can have answers from everyone.
Yeah, this is a very interesting question, Meenal. The thing is, we are not able to put COVID into a particular box and say, okay, this many days and patients will recover. What we have seen from the extensive COVID admissions in my hospital and the morbidities that follow after that, we have seen that patients take up to a month for complete recovery, or until they can be completely fit to resume their daily routine. We have seen patients have tiredness, sometimes breathlessness. Until they're able to do the 6-minute walk test. We ask them to do the 6-minute walk test. And until then, we do not discharge the patients. So I would say around a month's time. But there have been outliers. There have been people who come back with pulmonary changes or respiratory distress, even after 1 month or even after 3 months also, or they can just have sudden cardiac attacks. So there have been a plethora of possibilities, and I think Dr. Soni would be able to highlight better about it.
Probably I fully agree with Dr. Soumya that even in post-COVID or long COVID syndrome, we are observing many of the problems which are quite disturbing, even mentally, physically, economically, and on all the aspects. And sometimes even with a significant lung involvement early, Dr. Dhar will be the best person to guide on this. But then it has been observed that at least 2 to 3 months is the period when patient can have a little recovery. And we have got patients admitted even after 1.5 months of recovering from the COVID and coming out of ICU, they are still on minimum intranasal oxygen with a little physical activity only and still hospitalized. Dr. Rajadhar, your comments on this. This is a huge problem.
It is a huge problem, Dr. Soni, and sort of going along with what Soumya and you said. So we are in the middle of writing a white paper for Lung India, which you should read in the next edition, and doing a national post-COVID registry. Now, we think that there's a problem with calling this post-COVID fibrosis in the first place. because if you call it fibrosis, then by definition, you are calling it an irreversible process. And like Soumya said and Dr. Soni said, a large majority of these patients have what can be termed as reversible diffuse parenchymal lung disease. So it's DPLD, which seems to be reversible. Fibrosis, if there's good going traction bronchiectasis, if there's honeycombing, it's largely an irreversible process. So when you say post-COVID fibrosis, you actually mean less than 5% of patients who have severe COVID pneumonia. Less than 5% of those patients will have either static or progressive interstitial lung disease. Now, even that 5% is a large number in a country of our size, but it's still a much smaller number. For the patients who have ground glass opacities, for the patients who have post-COVID consolidation, for patients who have a little bit of scarring or a large amount of scarring on the lung, almost miraculously, CT severity scores of 20 out of 25 within a period of 6 weeks to 3 months have become 2 out of 25 or 5 out of 25. Who are the patients who are most likely to have fibrosis? So it's interestingly men, smokers, elderly, patients with comorbidities in the form of COPD and hypertension who seem to develop the most amount of fibrosis in an Indian population with the limited data that we have till date. Antifibrotics, which we have not spoken about, and maybe we should avoid the topic, but antifibrotics is for that very small minority of population. In the last few months, we have thrown antifibrotics at patients sort of like water, like we threw aspirin to patients, and that's something which is completely wrong. The steroids in these patients are important, but that's a small dose of steroids, and you need to be cautious about weaning the patient off steroids quickly, because otherwise you end up with secondary infections that all of us, the black fungus, the green fungus, the blue fungus, all of these become important and relevant questions if the steroids continue forever.
So Raja, we saw quite a few cases of pulmonary mucor along with rhino-orbital mucor. So I don't know if you have the same experience in Kolkata.
I've seen about 3 till date, Soumya. So I've seen 3 cases of mucor. I've actually seen far more of aspergillus. So aspergillus is a fungus that we seem to see far more often as compared to mucor, as opposed to places like Gujarat and Maharashtra, where there seems to be a disproportionate amount of mucor. I can see Meenal nervously looking at the watch. So she's got more questions up her sleeve and she needs to finish.
No, nothing like that. Yeah.
Yeah.
Okay, so this question was asked by Dr. Lata Devi, and thank you very much for answering, all of you. Now, moving to our next question, which is by Dr. Wilson. This is to Dr. Rajadhar. What is the treatment for ARDS in COVID?
So that's a good question. So when we talk about severe COVID pneumonia, what these patients end up having is an ARDS-like phenomenon. So that's an hyperinflammatory insult. All of you have heard about the now famous cytokine surge, which happens in patients with COVID. And that's the ARDS that you identify with. So the management of the ARDS would not be any different as compared to what it would be for ARDS in general. The only big difference, the capital line difference at the top, is that the evidence for steroids in post-COVID ARDS seems to be better, greater, as compared to what we have for ARDS for elsewhere. If you now think of the now famous recovery trial, which looks at 10 days of 6 milligrams of dexamethasone, that's the only drug which seems to work in patients who have severe COVID pneumonia or COVID-related ARDS at that particular stipulated dose and for that duration. So I think ARDS, the supportive management, the lung protective ventilation, all is similar to what you have in ARDS. The steroid data seems to be more strong in patients with COVID as compared to other causes of ARDS.
Sure, sir. Dr. Soumya, Dr. Soni, you want to add anything here?
I think we all agree that that in COVID, particularly with the lung infections, and steroids have got a very definite role to play. And apart from this antifibrotic, yes, I fully agree that it is a fibrogenic process rather than fibrosis which occurs in this lung during the COVID period of 1 to 2 months or 3 months. And in that, rather than antifibrotics, it is the role of steroids which is a little more important and gives more benefit to these patients in resolving the lung infections rather than antifibrotic drugs, which may prove to be a little more harmful rather than the beneficial altogether. The same is for ARDS as well, that inhaled corticosteroids and others are more important for us to follow.
Sure, sir. Okay.
Meanwhile, I would just like to add remdesivir. It has been hailed both as a hero and a villain. Initially, they celebrated it a lot. Then they said it was of no use. From our hospital institution, this one, remdesivir has been beneficial. But of course, I will leave it to the realm of Dr. Raja and Dr. Soni. So that's the only point I want.
Sure, sure, Dr. Soumya. So now moving to our next question. This is to Dr. Soumya. Where is the place of decongestants when we are managing COVID patients? And if we are using decongestants, then is it favorable or unfavorable?
Decongestants don't have a role per se in COVID-19, I would say. But of course, decongestants can be used in allergic rhinitis initially, so that the fluticasone furoate spray or any spray, the anti-allergic, the intranasal corticosteroid spray that we give can have better reach. So it is also, once the reach is better, patients will also feel that the nasal obstruction is better. So it is a short duration of treatment. It does have a role. COVID-19, we do not give it unless patient complains of severe nasal obstruction and wants to get some relief from that. We do not prescribe it.
Sure, ma'am. Yeah.
Soumya, I was listening to one of my other ENT colleagues speaking on a similar forum a few days ago, and they spoke about a small trial, but quite a convincing trial about using intranasal fluticasone for the treatment of refractory anosmia. So about 80 patients, 2 arms, looking at treatment of anosmia, which does not seem to go away with intranasal fluticasone. So quick comment from you.
Definitely. We have also tried intranasal steroids for treatment of anosmia. Along with that, we do what is called as olfactory training. So we usually admit the patient. We then give them, a spectrum of different odors, and we make them keep smelling it on a daily basis. And we have a chart to document whether it is improving or not. So we teach them olfactory training and intranasal steroids. We have found benefit with both for anosmia.
Sure, ma'am. Yeah, okay. So now moving to our next question. This is to Dr. Soni. Yes. Whether inhaled corticosteroids and steroid nebulization are contraindicated in glaucoma patients.
Glaucoma patient? Oh. For glaucoma patient, inhaled corticosteroids, I don't think that there is any contraindication. It is the efforts which increase the blood pressure and put a little stress, which are more detrimental for any glaucoma patient to do that. But for the inhalation of the corticosteroids, rather it will relieve the symptoms and relieve the stress on the patient itself. And I think it will be beneficial rather than, the steroids as glaucoma, cataract or other comorbidities are concerned. Oral may have a little detrimental role or effect. But as far as inhaled or nebulization is concerned, I don't think that there is any significant effect on the glaucoma as such. But only one request, that I've got an emergency call, so I would like to take an excuse, and I think Dr. Rajadhar and Dr. Soumya, they are taking the question nicely, and on my behalf, they will also be able to answer the rest of the questions.
Sure, okay? Sir, no problem. Thank you very much, sir.
Thank you very much. Yeah. Thank you very much. I enjoyed. Thank you.
Thank you. So just to add to what Dr. Soni said, Meenal, I think our audience is actually alluding to the use of long-acting muscarinic antagonist and short-acting muscarinic antagonists. So the muscarinic antagonists actually increase intraocular pressure and make glaucoma worse. And it's been known to precipitate a glaucoma crisis when they've been used frequently in patients with glaucoma. So I think that's where the question arises from. So it's not steroids, as Dr. Soni said, it's more to do with the muscarinic antagonist, be that short or long-acting.
Sure, sir. Yes. Okay. So, sir, next question is to you. What about bronchodilator role in COVID? As I'm sure you have already covered budesonide, etc., in your presentation. However, this question is like, what about the combination like budesonide plus formoterol?
Sure. So that's a good question. It's a good question because, like most questions in COVID, this is an unanswered question, but I'll try and hypothesize. So I don't think bronchodilators have an advantage in patients who have COVID-19 infection. However, there are a certain category of patients where COVID-19 as a respiratory virus acts as a trigger to exacerbate asthma. So be it formoterol budesonide, be it salmeterol fluticasone, and more from a formoterol budesonide perspective, using it as a bronchodilator when there is definite evidence of bronchospasm, mostly in the background of someone who's got asthma, known asthma, and has an exacerbation, there would be a role for a bronchodilator plus an inhaled corticosteroid. However, from a COVID-19 perspective, if you're trying to reduce hospitalizations and emergency visits, the trials that we've had, and ours is the third trial that we spoke about, it's been looking at inhaled corticosteroid rather than looking at a combination. I'll just add something else, Meenal, which I think is important, and sort of before I forget.
Sure, sir, please. Yeah.
So Dr. Ruby Pavankar has put in a message which talks about having adrenaline handy in vaccination centers. And I think that's a very important message for the country. The fact that while we don't have epinephrine, which we should have access to, centers which are vaccinating large scale, or even centers which are vaccinating small scale, or who are doing vaccination camps, should have crash trolleys where there is access to adrenaline as a replacement to the epinephrine that we have all known in Western countries, in case there's anaphylaxis. And this is an important message for the entire audience who's listening in today.
Sure, sir. Thank you very much. So now next question is to Dr. Soumya. Can allergic rhinitis be treated with montelukast and fexofenadine without intranasal corticosteroids?
It depends on the severity of the allergic rhinitis. So again, I would like to go back to the area guidelines, that is allergic rhinitis and its impact on asthma. So based on that, if it is a mild intermittent type of allergic rhinitis, just montelukast with an antihistamine we can use. But if the patient is suffering for a longer duration, it is better to use an intranasal corticosteroid so that better control is reached.
Right. Okay.
Can I just add to that? I wonder what prompts that question. And I actually asked that with a particular purpose. I'm not sure why you would want to treat someone with allergic rhinitis, which is severe, significant, without an intranasal steroid. It's like saying that I would treat asthma with montelukast and levocetrizine or fexofenadine without using an inhaled corticosteroid. I think the mindset has to change. If someone has allergic rhinitis, if someone has asthma, which is an inflammatory disease of the airway, an anti-inflammatory, and the best anti-inflammatory we'll know till date is an inhaled steroid, be that intranasal or be that inhaled. And I think that's something that's compulsory. You have to do it. Why would you try and find ways around not using it and still treat the disease?
Yes, I concur, because as such, intranasal corticosteroids have got a very good safety profile. So there we wouldn't, be hurting the patient too much by even adding that on. That is true.
Also, sir, I would just add one more question here, which we keep getting. That in patients who are having allergic rhinitis, but who had COVID before. So in such patients, there is an apprehension to start intranasal corticosteroids with the assumption that it might lead to mucormycosis, as we keep hearing that excessive usage of steroids are leading to this. Maybe that is one of the reasons why there is this apprehension.
Yeah, so quick message, Meenal. I think it is no different with inhaled steroids as it is with intranasal. I think you said excessive use of steroids rather than use of steroids. And I think it's the word excessive which needs to be underlined in red. If you try and avoid steroids completely, you will probably have more of the COVID-related complications, fearing that you might get mucormycosis or other fungal infections. Topical steroids do not really cause these complications, and this has been studied on a large scale even before COVID came in. And I think it's important to use topical steroids because that avoids the use of oral steroids, which are far more likely to cause these complications.
Sure,
To add one more point, several studies have recommended, and they say there is no problem using intranasal steroids. But it is very important for doctors to know that for mucormycosis to be there, there has to be an underlying condition of hyperglycemia. Now, without hyperglycemia, we have not seen any mucor. They might say we have never been a diabetic, but we know for a fact now that COVID itself can destroy the islets of Langerhans, so it can induce hyperglycemia. So a non-diabetic can suddenly have high blood sugars. And it's also the over-the-counter oral steroid medications, but not the intranasal steroids.
Sure, ma'am. Thank you very much. So, sir, moving to the next question, which is to you, Dr. Rajendra is asking, can prophylactic use of antifibrotics prevent lung fibrosis in COVID patients with marked lung involvement during COVID?
So I think the question, this is probably not a question for this particular forum, so I'll keep it brief, Meenal.
Sure.
So I think if someone has got gross lung fibrosis already, lung involvement already, you wouldn't say that you're using it as prevention. So when you say, as soon as you say prevention, it would be any patient with severe COVID-19. And I would strongly recommend not to do that. However, if you have a patient who is the phenotype where there's a high risk, if you see CT features which are suggestive of early fibrosis, and this is ideally 6 weeks post-discharge after severe COVID, if the patient continues to be symptomatic, if there are lung function parameters like forced vital capacity, the FVC, which is low in these patients who are recovering, then a course of antifibrotics would be judicious, it would be useful, but it will be a minority of patients rather than a majority. I would not say that any patient with severe COVID should take an antifibrotic to prevent onset of fibrosis, because there's not an iota of data to support that.
Sure, sir. Okay, so there is one question, there are multiple questions related to vaccination, but many of them are already answered in our discussion. So I'll just quickly take this one question to Dr. Soumya. If patient is already taking oral or injectable steroid, should they take COVID vaccine or should they postpone it?
Now, it depends for what condition they are taking. For example, if it is autoimmune diseases, okay, then the patient might be on steroids to suppress it. So they could be severe cases of psoriasis or vaginas or something. So they've been put on steroid for a particular condition. You're talking about vaccination, Dr. Meenal?
Yes.
Yeah. So I think vaccination can be taken. Vaccination does not have a bearing on this. I think Dr. Raja can correct me, but I feel they can go ahead with the vaccine.
I agree with you, Soumya. The only point is that, like the disease process, you want to be on the lowest dose of maintenance steroid when you're taking the vaccine, right? So you need to come down to the lowest dose if possible. So you should not be taking a vaccine when you've got 30 milligrams of oral prednisolone on board, for instance. And this is all anecdotal. I would try with the connective tissue disease patients, the autoimmune diseases that Soumya spoke about, I would try and take the dose of the steroids to as low as possible at maintenance and then give the steroid rather than a higher dose of steroid is what we would mandate. But I completely agree that vaccination should be taken and steroid intake is not a contraindication for vaccination.
Sure, sir. Thank you very much. So, ma'am, next question is again to you. What is your experience with managing cytokine storm with usage of leukotriene antagonist like montelukast?
Meenal, this could be my hypothesis, but it is quite interesting because I think all the papers also have shown, all the literature has shown that allergic rhinitis and asthma do not pose an extra risk for COVID-19 storm. So they have hypothesized that the angiotensin converting enzyme receptor to which the coronavirus attaches, that itself is low in atopic individuals. That is one thing. The second thing, which is my hypothesis, is that When patients have the symptoms of COVID, often they confuse it for allergic rhinitis, or they usually confuse it for allergic rhinitis. So they don't want to accept that, they don't want to go for the RT-PCR test. They always keep waiting. Let me see, let me watch. Maybe it is not COVID, this sort of a mentality. So they go to the nearest chemist who will give them probably montelukast with levocetirizine or montelukast with fexofenadine. Now, in my slides, what I showed about drug repurposing, we have seen that both montelukast and fexofenadine have a major role in preventing the release of inflammatory mediators, which could lead to this cytokine storm. So, without that knowledge, I think they are benefited. Also, when patients come to the OPD, many of the times I tell them, why don't you get an RT-PCR test done? Now, it is not mandatory. We cannot push the patient and say, you have to get it done. Sometimes the patient will just refuse. They'll say, no, you just give me some medications. So we give them this montelukast, and then we'll say, okay, fine, let us see. If you're not feeling better, you come back. They might come back after 3 to 4 days with further symptoms, and then we check and it is COVID. But to a certain extent, this might protect. They might not go into that full storm. So this is some sort of a clinical trial that we are doing without our own knowledge, because we are treating COVID-19 as allergy in the initial stages. So this is, of course, my hypothesis, but I feel that we do put a lot of patients on montelukast and fexofenadine combination also generally in the OPD. The other thing, in our hospital, although it is not recommended, we do give tablet montelukast for 10 mg for every patient who's admitted with COVID, because there are few studies which have shown that it can decrease the inflammatory mediators, the interleukins, everything. So the cytokine storm stage can be reduced. And that is a protocol that we follow. And what I have seen is the patients who come in with complications are usually the ones who have presented late to the hospital. They're not the ones. If they come in early, I'm sure most patients do well with COVID-19.
So, sir, this question is to you. What extra measures an asthmatic patient should follow if they are suffering with COVID-19?
So I think we discussed this, Meenal. So very, very briefly, if you have asthma, we know that there's no extra risk of having COVID-19. Neither is there increased severity of COVID-19 in case you happen to have COVID. The important thing is to try and avoid triggers and to make sure that you're on an inhaled corticosteroid and other asthma treatment as per regular. Because the country is in a lockdown, because people are isolated, the chances of experiencing the triggers is low anyway. If you're going into crowded places for whatever reason, maybe the profile of job that you do, you need to make sure that all the general COVID appropriate behavior we keep talking about in the way of the sanitization, masking, and social distancing needs to be adopted. But this is not just true for asthmatics, it's true for any individual who is living in the pandemic throughout the globe today. So I think that's about it. That's the gist of it. I think asthma is a relatively safe disease in COVID. And as long as you take the treatment regularly without fearing about the repercussions of inhaled corticosteroids and what it might do to the COVID, people with asthma would be fine in this pandemic.
Sure, sir, sure. So now we will take this question to Dr. Soumya. Can you help us understand the role of antibiotics in COVID? Anything specific we should focus on?
Role of antibiotics in COVID. This is a very interesting and dicey question as well, because there is no clear-cut evidence to say any particular antibiotic would help. However, azithromycin, by default, most practitioners do prescribe azithromycin because it is supposed to benefit the lower airways. So that is given. But personally, I don't feel there is an indication for giving antibiotics for COVID-19. It has to be treated with the same respect as we treat any other viral fever, just symptomatically, and wait. If there is something more evolving, then we go into other drugs that we can use.
Sure, ma'am. Yeah, please, sir.
The quick word to add to what Soumya said, all of which I completely agree to. So you use antibiotics in COVID from two different perspectives. One is there are certain antibiotics which also seem to have an antiviral effect. Soumya spoke about azithromycin. The other antibiotic that's been spoken about widely is doxycycline. Both of these drugs seem to have an antiviral effect. We've just completed a doxycycline trial, an Indian trial with 20 centers. And hopefully, this is with Southampton University who gave us a grant to do the study. And hopefully, again, watch this space. We'll hopefully come out with the results soon. I hope, fingers crossed, that the study will show some improvement. That's the first part. The second is about secondary infections. So co-infections is when you get COVID and you get another infection along with it. That's about 3 to 4% of the Indian population who get co-infections. Secondary infections is the larger number. That's about 10 to 15% of population. And in both these scenarios, you would think of adding in an antibiotic. Who are these patients? So patients with a very high fever, patients who have cough with expectoration, patients who have other features of atypical pneumonia aside from viral pneumonias. All these patients with a high inflammatory marker, a very high CRP, a very high procal, all these patients would be candidates for antibiotics. But like Soumya said, here you're treating a secondary infection rather than treating COVID-19 infection.
Agree. And also ivermectin. I don't know to what extent ivermectin helps. So there has been a cocktail of drugs. I mean, people are experimenting in their own sweet ways. Hope something works.
Sure, ma'am. Okay. So we'll just take this last question to each one of you. Now, this question is to ma'am. This is again little generic. Please throw some light on booster dose of vaccine for healthcare workers.
Now, as per the recommendations, we all had 2 doses of the vaccine. We had Covishield 2 doses and then Covaxin also. But now they're talking about having the 3rd dose. I'm not sure about the guidelines for that. I think I will just pass the question to Dr. Raja.
So the trials are on. There's the Covaxin trial, there's the Covishield trial, there's the trial with Moderna. The trial is actually being done on healthcare workers. I don't think the healthcare workers will be the only people getting the booster. My gut feeling is, the gut feeling of a lot of pulmonologists in the country is that there will be a booster. The booster will be between 6 months to a year from getting your 2nd dose of COVID-19 vaccine, whichever vaccine you've opted for or got. However, I think we need to finish vaccinating about 70% of our population and gain herd immunity with 2 doses before we went into the terrain of the 3rd and booster dose of vaccine. And in my book, while we are hoping that will happen by the end of the year, it's probably going to take a year more before we manage to attain 70% vaccination of our population. So the booster dose will be there. Maybe it will happen, start off with healthcare workers like it did with vaccination itself. But when, I'm not so sure. It's still watch this space.
Janssen has come up with that single dose vaccine for your lifetime and things like that. So I really don't know if it would work with just 1 dose, because coronaviruses as a family are the sort of viruses which tend to keep on mutating. So, we'll have to even keep changing the vaccine also has to be upgraded to match this mutation. I don't think it's like, one size fits all philosophy, especially with relation to coronavirus and its mutagenicity.
Sure.
Right. So with this, just a quick request to Dr. Soumya and Dr. Rajadhar to give a message to all our audience. What do you like? Anything, your take-home message for everyone?
Dr. Raja will go first.
Soumya first. Always ladies first, please.
Okay, Dr. Meenal, so what has fascinated me about today's talk is about drug repurposing. So I think this COVID-19 has been a teacher for us in several respects. And I feel that one of the greatest things it has taught us is about trying to find solutions in a very constrained period of time. Okay, so if we can see whatever resources we already have so that it does not go through the whole drill of animal trials and all those clinical trials before it comes on humans, if we can use whatever resources we have, then I think we will be able to cater to the needs of the COVID-19 virus and any other upcoming viruses also. It is very important that we should have a bench or a bedside to molecular level connect between physicians and pure scientists. That is a big divide which is there in our country. So we're all clinicians, we look at the big picture. We're looking at running nose, sneezing, and we really don't know what's going on behind the scenes. I feel that we need to bridge that gap. So have the clinicians and all the pure scientists collaborate much more so that we understand what exactly is the story behind the symptom that we see. And drug repurposing is something that India should look at in great depth. And these are not the only two drugs that I mentioned was montelukast and fexofenadine, but there are so many beautiful gems which are hidden out there. And I think it would be nice if you could explore. So that's my message for today.
Sure, ma'am. Over to you, sir.
The wonderful message, Soumya, really nice message. Message from my side is that hopefully with today's webinar, we have managed to dispel some of the myths that are associated with the presence of allergy and not getting vaccinated for COVID-19. I think strong message from our side that if you have allergy, if you have asthma, the first message is please make sure that you use appropriate drugs to keep these allergies under control. That's one message. The second message is that if you have allergic rhinitis and asthma, it's unlikely that you will come to a lot of harm, extra harm from COVID-19. That's the second message. So that's a reassuring message. And the third and maybe the strongest message is that allergy alone does not mandate that you should not get vaccinated. I've seen so many people, and I'm sure Soumya and Dr. Soni, who left us a little while ago, would have seen patients who have come and told us, I'm allergic to bananas, for instance. I'm allergic to animal dander, pollen. I cannot take the vaccine. Even the medical personnel who were supposed to administer the vaccine told us that we should not get vaccinated. So that's a strong message for the audience, for doctors, for healthcare workers, that having allergy, being allergic is something, as Soumya said, which is true in 30% of our population. 1 in 3 people are allergic to something in an Indian population. They have allergic rhinitis, for instance. And that is not a contraindication to vaccination. It's only a very rare patient who are actually allergic to a component of the vaccine where you think that vaccine should be contraindicated, vaccination should be contraindicated. And that's one carry home message I want people to take with them.
Sure, sir. Thank you very much.
I mean, one more point.
Yeah, sorry.
One more point, sorry. So this is for the world in general and for India. See, I feel even this asthma and allergic rhinitis, everything, to a large extent has decreased because everyone is masking up, and also the air quality index of the country has dramatically improved. So we should look at green energy and trying to see that we improve the air quality index. All of us should be aware of the environment. This is a very generic message, but I think it requires emphasis on and on. Thank you.
Sure, ma'am. Yeah. Thank you very much, both of you, for this wonderful take-home messages. I guess it was very crisp and to the point. So we are already done with our allotted time. So thank you very much, Dr. Raja, Dr. Soumya, and Dr. Soni, for wonderful sessions and an engaging panel discussion. It was truly an academic treat. I'm sure. Yeah.
Meenal, wonderfully moderated. Well done. You did extremely well with the deluge of questions. And a very big congratulations to the entire Sanofi team for having conducted this meeting so nicely. And to
thank you very much,
for having endorsed us.
Yeah, very nice of you, sir.
I second all that. Dr. Raja stole all my words.